بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will start a new topic in pediatric imaging, which will deal with imaging of the gastrointestinal tract. This topic will be divided into two parts. The first one will deal with the esophagus and the stomach, and the second one will deal with the small and large bowel. Then, as you all know, that we have too many modalities for evaluation of the gastrointestinal tract, including the conventional X-rays, which are very, very important in the pediatric population or pediatric evaluation. Then the contrast studies, including barium and gastrographin, ultrasound, which is a major diagnostic modality, CT, MRI, and some of the interventional techniques. The value of the plain X-ray, especially in pediatric population, is very, very important. By plain films, we can detect radiopaque foreign bodies. We can assess the gas shadow, which is very important in evaluation of GI congenital anomalies, as I will mention. It detects also organomegaly, especially whenever the liver is enlarged or the spleen. It detects calcifications and stones, also can help in the evaluation of the lung basis, which may provide a clue for many of the abdominal pathologies. Also, it can show bony abnormalities, which can help also in the diagnosis. Barium studies are helpful in assessment of the position of the bowel for diagnosis of rotational abnormalities and mesenteric volvulus, for example, diagnosis of intestinal obstruction, diagnosis of atresia and stenotic segments, assessment of the fistulae and the blind pouches, diagnosis of vascular links, and it may have a therapeutic role as in reduction, for example, of intussusception and so on. Barium, which is used in the diagnostic techniques, is the barium sulfate, which is one of the best contrast media for evaluation of the gastrointestinal tract because it produces excellent opacification and good mucosal coating. It is also completely inert with no side effects for its use. There are many preparations available for use in the children in particular, such as those which are flavored by many of the fruits or chocolate, for example, in order to be palatable for the children. Then gastrographin is a water-soluble contrast material that can be also in the gastrointestinal tract. It is orally administered and is usually administered in children in the neonates, and whenever you are suspecting bowel perforation or when in cases you are suspecting intestinal obstruction. This gastrographin has a high osmolarity and it should be used with very cautious, especially in dehydrated children. Then we started the evaluation of the esophagus and the examination of the esophagus by the barium is known as barium swallow, and we may introduce barium through the nasogastric tube, put in the proximal part, introduced into the proximal part of the esophagus, then we inject barium, or if the child can swallow, we can give him the barium preparation so he can swallow. Then we should look for the passage of the barium through the esophagus under screen control, and we have projections in the frontal view, in the lateral view, and maybe in the oblique views to see or to look at the esophagus from different aspects. And if you have the lateral view of the esophagus, there may be some indentations along the anterior aspect of the esophagus, which are usually caused by the aorta, the pulmonary artery, and also the left main bronchus. In the middle third, lower down, you got the impression of the left atrium and maybe the left ventricle if it is enlarged. And we have two types of congenital esophageal abnormalities, the congenital and the acquired lesions. Congenital lesions will include esophageal duplication, atresia, tracheoesophageal fistula, esophageal stenosis, vascular rings, and hiatus hernia. You know that duplication of the esophagus, complete duplication of the esophagus is considered, according to the literature, is one of the extremely rare conditions. And this is a case where you can see that there are complete duplication of the esophagus. We have two lumens and both are opacified with barium and both are connected to the stomach. Then esophagus is considered the second most common location for duplication after the ileum. The esophageal duplication accounts for about 20% of all GI duplications. Usually, the duplication is in the form of a cyst adjacent to the esophagus, whether it is communicating with the esophageal lumen or not. And this esophageal duplication cyst has been discussed thoroughly in mediastinal pathology, but you know that many of the patients are usually asymptomatic. Esophageal duplication cyst may compress the esophagus, resulting in dysphagia, for example. Then you can see the esophageal duplication cyst by CT, by ultrasound, or by MRI. It is a well-defined cystic lesion in the posterior mediastinum related to the course of the esophagus. And this system may communicate with the esophageal lumen. Then if you introduce barium, it will fill with barium, or commonly it is not communicating with the esophagus and it contains clear fluid with no evidence of internal septation, mural nodules, or calcifications. Then this is a CT of a 19-month-old boy with a cystic lesion in the mediastinum related to the site or the course of the upper esophagus. And the lesion compresses and displaces the trachea as well as the vessels in the mediastinum anteriorly. You know that cysts in the mediastinum can show the 7 criteria of simple cysts all over the body, including 3 positive and 4 negative criteria. The positive criteria are clear fluid content, paper thin wall, sharp well-defined margin. The negative criteria, no septation, no calcification, no mural nodules, or no contrast enhancement. But sometimes you may see in the mediastinal cysts some internal septation, and also you can see flecks of calcification. And this is the classic example of an esophageal duplication cyst in almost a classic position. You see the cyst is located in the paravertebral gutter, and part of the cyst is insinuating itself between the heart and the descending aorta. This sign is diagnostic that this lesion is not of pulmonary origin. It arises in the mediastinum in this particular area. Then because of the tight space, it has grown to the right side. Another example, by plain film, you can see a shadow in the posterior mediastinum. This has a lot of differential diagnoses, including neurogenic tumors and so on. But by CT or by ultrasound, whenever you see the cystic nature of the lesion, and you know that this is esophageal duplication cyst. The esophageal duplication cyst can be in the differential diagnosis of many of the mediastinal cysts in the pediatric age group, like the pleuropericardial cyst, which is usually located at the cardiophrenic angle, cystic hygroma, which is usually located in the neck and extends into the mediastinum, neuroenteric cyst, which is usually associated with abnormalities in the vertebrae, anterior or lateral meningocele, which is a little bit rare condition, but it can occur. Esophageal duplication cyst, thyroid, colloid cyst, and thymic cyst. Also, pseudopancreatic cyst may reach the posterior mediastinum through the aortic or the esophageal hiatus. Then we came to the esophageal atresia, and this is a congenital anomaly due to incomplete formation of the esophagus and may be associated with tracheoesophageal fistula or may not be there may not be a fistulous communication with the trachea. The exact cause is unknown, but it is assumed to be incomplete separation of the primitive foregut into the trachea and the esophagus. And we have a classification for this tracheoesophageal fistula, and these are the 5 types. In esophageal atresia is suspected in cases of polyhydramnios, excessive salivation, choking or cyanosis during feeding, inability to pass the nasogastric tube or a feeding tube to the stomach. The most common type is this one, which represents about 85% of the cases where you got blind proximal esophageal pouch with fistulous communication between the distal part of the esophagus and the trachea. The less common type, which where you got two blind pouches, or in 4% you got what is known as H-shaped fistula. The esophagus is almost good, but it has a communication to the trachea. Then this is rare, 1%, where the proximal and distal pouches are connected to the trachea, and this is also rare where the proximal pouch is connected while the distal pouch is not. Then the most common type is that you got proximal blind pouch with some communication between the distal pouch and the trachea. And this is the diagnosis of this pathology is very easy whenever you see that the introduced nasogastric tube is coiled and go back into the esophagus, meaning that there is a blind pouch here. Then look at the abdomen and you see air in the stomach and the intestine, meaning that this air has came to the stomach through the communication between the distal pouch and the trachea. Then these are once more the types of tracheoesophageal fistula. The most common one, the H type, and the two rarest type, as I have mentioned. And here, if you want to pass the nasogastric tube, it will stop here, meaning that there is a blind pouch. Look at the abdomen and you see air, then there should be a direct communication between the lower pouch and the trachea. And by introduction of barium, you see that barium cannot pass this area, meaning that the proximal pouch is blind, and this air is coming from the distal pouch. And this is the commonest type, as I have mentioned, which is seen in about 85% of the cases. The proximal pouch is blind, and air will come through the trachea into the lower pouch to the abdomen. And this is once more the most common type of esophageal atresia. You got blind pouch with coiled nasogastric tube, air in the abdomen, diagnostic of the blind pouch with fistula with the distal pouch. Another appearance, and you see the coiled tube and the air in the abdomen. Also, a third example, this is the feeding tube, which is coiled into the upper esophageal pouch, and look in the abdomen and you see air. This means that there should be a communication between the lower pouch and the trachea. But if you see that the tube is not passing and this pouch is blind, look at the abdomen, there is no air, meaning that there is no communication between the distal pouch and the trachea, and this is the less common type where the two pouches are blind. And this is the communication between the blind proximal pouch, and here is the nasogastric tube. This is the proximal pouch which is blind, and there is a very narrow communication between the pouch and the trachea with consequent passage of the barium into the trachea. Then here this patient is, or this infant is presenting by recurrent chest infection with patchy areas of consolidation with suspected tracheoesophageal fistula. The tube for introduction of barium is a little bit pushed downward, so you cannot see the site of the fistula. But if you pull the tube proximally and you inject barium, then you can see the communication between the esophagus and the trachea. So, whenever you are suspecting tracheoesophageal fistula, do not push the tube into the esophagus lower down, but you just put the tube in the proximal part of the esophagus or even in the hypopharynx and inject barium so that you cannot miss this particular lesion. Congenital esophageal stenosis may be seen as this one, which is usually a limited segment of relative esophageal narrowing seen commonly in the middle and the distal part of the esophagus, and may be considered a variant of uh, esophageal atresia, meaning that the esophagus was about to be atretic, and we go in the previous story, but the result is only in this form of mild degree of stenosis. And you remember that whenever you have the lateral view of the esophagus filled with barium, sometimes you may got some indentations along the anterior aspect, but there should not be indentations along the posterior aspect of the esophagus in normal conditions. And if you see indentation on the posterior aspect of the esophagus during barium swallowing, you should think of this impression is due to abnormal vessel. And you think of vascular rings, and you should now have the CT angiography to assess the type and the degree of vascular ring. Hiatus hernia can be seen in infant and the children as also in adults. The same applies for both, and the diagnosis depends on the detection of a part of the stomach above the diaphragm, either with the gastroesophageal junction or the gastroesophageal junction is under the diaphragm and part of the stomach is above the diaphragm, and this is known as the paraesophageal or rolling hiatus hernia. But when the gastroesophageal junction and the part of the stomach are above the diaphragm, this is known as a sliding hiatus hernia. And this is an example of a sliding hiatus hernia. And you see the gastroesophageal junction and part of the fundus of the stomach are located above the diaphragm. And this is also another example of sliding hiatus hernia. The gastroesophageal junction as well as part of the stomach are seen above the diaphragm. Then we came to acquired esophageal abnormalities. We will discuss the reflux, the achalasia, foreign body ingestion, caustic ingestion, and esophageal strictures, and finally the esophageal varices. Gastroesophageal reflux disease or GERD uh, is seen in children and also seen in adults. It is the reflux is considered one of the commonest indications for performing barium studies in children. This disease will result in symptoms like frequent regurgitation, choking, apnea, and of course, some of the aspiration pneumonias. Then the variable swallow has only 50% sensitivity to detect reflux in children. During swallowing, there should be occlusion of the gastroesophageal junction, but in this case, you see that the gastroesophageal junction is widely open with reflux of barium from the stomach into the lower part of the esophagus. Then during normal conditions, after the child swallows the food or barium, there should no be residual barium in the esophagus in the resting phase. But if you have this image under, or you look under screen control, and you see barium is almost totally filling the esophagus, or even filling the lower part of the esophagus, then you consider the possibility of gastroesophageal reflux. Of course, reflux is common with patients with hiatus hernia, but it can also be present without the presence of hiatus hernia. Then achalasia is considered rare in children, and the incidence is about 1 per 100,000 cases, and fewer than 5% of those with achalasia present in the childhood. And the symptoms of achalasia in infants are similar to gastroesophageal reflux, while the symptoms in children are similar to those of adults, including dysphagia, chest pain, cough, vomiting, and poor weight gain. Achalasia results from a sort of neuromuscular incoordination in the distal part of the esophagus, which will not open in front of the bolus. Then you got tight narrowing of the distal part of the esophagus with consequent considerable dilatation of the esophagus proximal. And you see here that the esophagus is dilated and is harboring a lot of barium with smooth tapering or narrowing of its distal part. This is known as the bird's beak sign or the parrot beak sign. Whenever you see that the distal segment of the esophagus is smoothly narrowed with proximal considerable dilatation. Then one of the treatments for this achalasia is to do an endoscopic myotomy of the affected segment of the esophagus. And this is an example in a patient with achalasia of the esophagus underwent oral endoscopic myotomy of the affected segment. And you can see the passage of barium in the first minute, after 3 minutes, and after 5 minutes after this myotomy. And then this follow-up study is performed on day 2 following the endoscopic myotomy, and you can see the free passage of barium through the distal part of the esophagus and complete evacuation of the esophagus after 5 minutes. 1 year later, you can see that the esophageal caliber has relatively reduced. There is free passage of the barium from the esophagus into the stomach. This is another example of achalasia. See a narrowing of the distal part of the esophagus with proximal dilatation, and those cases there is stagnation of food in the esophagus, which will allow the passage into the trachea and airways with frequent appearance of aspiration pneumonia. As you know, it is common on the right side but can be on both sides. And foreign bodies are uh, commonly seen in children either in the GI or in the respiratory tract. And you can see if the foreign body is radio opaque, and you can see it by the plain film. And if you see a coin like this in the frontal X-ray en face, and this indicates that this coin is present in the esophagus, because coins in the trachea are seen uh, on the by the lateral side of the coin, but the coin in the esophagus will be seen en face like this. And here you can confirm the site of the foreign body by the lateral view. This is the tracheal air column. The foreign body is posterior to it, meaning that it is in the esophagus. So in the frontal view of the chest X-ray, if you see the foreign body like this is esophageal. If you see like this, and this is tracheal foreign body. Then corrosive uh, may be accidentally taken by children and maybe also taken by adults in suicidal attempts, and they will result in coagulative necrosis of the mucosa and the underlying submucosal tissues of the esophagus, with the end result of a long segment of esophageal narrowing, with, of course, proximal dilatation of the esophageal segment. This may lead to shortening of the esophagus and pulling of the stomach into the chest, resulting in hiatus hernia as well. Then you see in this child, there is a very long segment of esophageal narrowing, usually starts at the level of the arch of the aorta and extends down to affect the whole esophagus. The proximal segment of the esophagus is usually dilated because of the resistance of flow through the strictured segment. And this is two different examples of corrosive stricture of the esophagus: proximal dilatation, long segment of smooth esophageal narrowing. Then one of the ways to treat this very long stricture in the esophagus is to replace the esophagus by a segment from the colon, and this is known as colon bypass surgery. And you have a segment from the colon and put it either subcutaneous or within the mediastinum to replace the or to maintain the flow of food from the pharynx to the stomach. Then acquired esophageal strictures have many causes. One of the common causes is after surgical repair of esophageal atresia and tracheoesophageal fistula, you may get residual narrowing of the esophagus. Also, the corrosive stricture or peptic esophagitis due to chronic gastroesophageal reflux disease. The symptoms of acquired esophageal strictures include dysphagia, chest pain, cough, and vomiting. And this is an example of the case of tracheoesophageal fistula, the H-shaped type, with residual esophageal stricture after surgery. This fistula has been closed surgically, and in the follow-up study after surgery, you got some narrowing in the middle part of the esophagus corresponding to the site of the fistula. Also, you may get stricture in the distal part of the esophagus secondary to reflux. Reflux will result in inflammation of the distal esophageal segment, and this inflammation will lead to ulceration, then followed by fibrosis, and this fibrous tissue will lead to narrowing of the distal part of the esophagus, and this is benign peptic stricture, as also seen in adult population. And you see here some sort of hiatus hernia with reflux and narrowing of the distal part of the esophagus, diagnostic of reflux esophagitis and esophageal stricture. And this is also another example. You see a hiatus hernia with relative narrowing of the distal segment of the esophagus, representing reflux esophagitis and peptic stricture of the distal part of the esophagus. Then another way of treatment of esophageal strictures is by balloon dilatation. And you see here a very tight esophageal stricture in the proximal part of the esophagus, and after balloon dilatation, and you got improvement of the site of the stricture with improvement of the flow of barium through the esophagus. Esophageal varices are seen in patients with liver cirrhosis and portal hypertension, The diagnosis of esophageal varices was previously performed by barium swallow, where you can see multiple worm-like filling defects along usually the distal part of the esophagus, but may extend upward. But nowadays, esophageal varices are diagnosed by endoscopy and also treated by endoscopic injection of sclerotherapy, and may be diagnosed by Doppler ultrasound and also by CT and MRI. Then we came to the stomach, and the stomach is examined by barium, and this examination is known as barium meal examination. And you give barium fluid either through the nasogastric tube or by oral administration. Then you put the child in different positions so that you can see the different parts of the stomach. Uh, each part of the stomach should be projected once filled with barium and another time filled with air, according to the position of the patient. Then here you see the fundus is full of barium, and here the fundus is full of air. Then the distal part of the body and the pylorus are here filled with air, and then they are filled with barium. This to diagnose filling defects, and this to diagnose ulcers. Then what are the congenital gastric disorders? The diverticulum, microgastria, gastric volvulus, and pyloric or pre-pyloric atresia or stenosis or webs. Then gastric diverticulum is rare in children and in adults as well, and it is usually located in the fundus. This is the most common site for gastric diverticulum near the gastroesophageal junction, and as any diverticulum in the body, it is prone to ulceration, prone to perforation, prone to bleed maybe sometimes. Then microgastria mean that the stomach is very, very small compared to the esophagus and to the duodenum. And this is one of the findings that can be seen in the clinical practice. Pyloric atresia, meaning that the outlet of the stomach is atretic. Then the patient will swallow air, and you got the stomach distended with air, with no air in the rest of the abdomen. This is known as single bubble sign, which means that the air is only located within the stomach. And this is also a single bubble sign. You see the nasogastric tube in the stomach, no air in the rest of the abdomen, diagnostic of pyloric atresia. Then volvulus of the stomach, meaning that the stomach is not in its anatomic location. We have two types, the organoaxial volvulus and the mesenteroaxial volvulus. This type is relatively uncommon, and this is common especially in patients with large hiatus hernia, allowing large part of the stomach to herniate and rotate in the hernia itself. In order to differentiate between both types, look at the greater curvature of the stomach. If the greater curvature of the stomach is above, and this is organoaxial. If the greater curvature of the stomach is to the right side, then this is mesenteroaxial volvulus. And this is the mesenteroaxial or mesentericoaxial volvulus, where you can see the greater curvature of the stomach is rotated to be on the right side of the patient. And the acquired gastric disorders, this is the very famous one, hypertrophic pyloric stenosis. Then you may got chemical gastritis, eosinophilic gastritis, Crohn's disease, bezoar, meaning foreign body in the stomach, gastric polyps, and lymphoma. The hypertrophic pyloric stenosis is an idiopathic thickening of the pyloric muscles, resulting in marked narrowing of the gastric outlet and maybe total obstruction of the gastric outlet. The incidence of pyloric stenosis is approximately 2 to 5 per 1,000 births per year. It typically occurs between the first week and the 3 months of age, and typically discovered, of course. The typical presentation is non-bilious projectile vomiting, and if you palpate the abdomen of the infant, you may feel an olive-like mass corresponds to the site of the pyloric canal. This pyloric stenosis may be associated with esophageal atresia or tracheoesophageal fistula or Turner syndrome. There are a lot of signs for describing the hypertrophic pyloric stenosis, and these are the string sign, which means that the pyloric canal is markedly narrowed like a string, or the double track sign, and you see here two tracks of barium through the pyloric canal, or the shoulder sign means that there is shouldering at the base of the duodenal cap corresponds to the hypertrophic pyloric muscles, and also the mushroom sign will describe this appearance, which is simulate mushroom, and the beak sign whenever the barium is obstructed here, resulting in a beak-like configuration before it can pass the stenotic segment to opacify the pyloric canal and the duodenum. Then ultrasound is a very, very good modality for diagnosis of hypertrophic pyloric stenosis, and you got marked thickening of the pyloric muscles and marked narrowing of the pyloric canal. Then the pyloric muscle thickness on a single layer is more than 3 millimeter, single layer, or the whole length is more than 13 millimeter, and the pyloric canal is markedly elongated, more than 15 to 17 millimeter. And if you look here and you see the typical appearance of elongation of the pyloric canal, thickening of the pyloric muscle, narrowing of the gastric outlet. And this sometimes is referred to as a cervix sign, because this appearance may simulate the cervix on ultrasound and also on MRI. There is thickening of the muscles of the pyloric canal and of the pylorus, and narrowing of the pyloric canal. This is the appearance by barium, and you got the elongation of the pyloric canal, narrowing, and you got the shoulder sign and the mushroom sign, as I have mentioned. Another case, and this is the postoperative specimen. You see the thickening of the pyloric muscles and the narrowing of the pyloric canal, which are also best appreciated here by barium. Polyps means that multiple lesions that produce filling defects in the stomach or the gastrointestinal tract. And in the children, it's common. The common polyps to be seen here are the juvenile polyps, which are usually of benign hyperplastic type. And this is a good example of multiple polyps in the stomach. In the barium-filled area, they appear as filling defects. In the air-filled areas, they are coated by barium from the outer surface. And one of the causes of apparent polyps and mucosal hypertrophy of the gastrointestinal tract in children is what is known as eosinophilic gastritis, where there is some nodularity in the small bowel and also in the stomach. Patients present with diarrhea and, of course, by eosinophilia in order to reach this particular diagnosis. Crohn's disease is a granulomatous disease, affects the gastrointestinal tract. Most commonly, it affects the terminal ileum, but it can affect the esophagus, it can affect the stomach, and any part of the gastrointestinal tract. This will result in marked hypertrophy of the mucosal lining of the stomach and the affected part of the duodenum. Later on, you got ulceration and fissuring, and may result at the end in fistulous communication between the bowel or between the adjacent organs or even between the bowel and the skin. Then gastric bezoar, meaning foreign body inside, and this foreign body may be one of three. Trichobezoar, meaning that a mass made of hair. Phytobezoar, a mass made of planets. And pharmacobezoar, a mass made of medications. The most common is this one, the trichobezoar, which is seen in infants and young females who are mentally disturbed. they sometimes swallow part of hair into the stomach. And you know that hair is undigestible. It will accumulate to form big mass that will later on obstruct the gastric lumen. And this is a mentally retarded female child with alopecia and decrease in appetite for few months. The barium swallow showed that the stomach is full with a big mass where barium goes between the intersects of the mass itself. And this mass, of course, is made of the patient's hair, and the hair is undigestible, as you can see here. Then, if you have the barium swallow, barium meal, you got a mobile mass within the stomach. And if you have a CT scan, for example, and you see the mass, and you can also see air within the meshes of the mass itself. And these masses are usually treated by surgery because they are big and cannot be removed by endoscope. So you open the stomach and you remove masses like this. And finally, tumors of the stomach are a little bit rare in the children. The well-known common lesion is the gastric lymphoma, and lymphoma will infiltrate the gastric wall, resulting in diffuse marked mural thickening. It may be associated with lymphadenopathy in the retroperitoneal area. Whenever you have a barium study and you got marked thickening of the gastric mucosal folds, reduction of the gastric capacity, and irregularity of the outline. This appearance can be uh, can be produced by many diseases like hypertrophic gastritis, menetrier disease, and gastric lymphoma, of course. But this appearance is almost typical for the gastric lymphoma, where you got considerable thickening of the gastric wall encroaching on the gastric lumen. And the diagnosis is confirmed by endoscopic biopsy. هذا وبالله التوفيق والحمد لله رب